First, let's talk about the minimum inhibitory concentration test. Basically what we do is we take tubes full of broth and we put a known amount of microbes in it. So suppose we want to test against Staphylococcus aureus. So we would put Staphylococcus aureus in. Say we've got another series of tubes that we put E. coli in. We've got our gram-positive with Staphylococcus aureus. We've got our gram-negative with E. coli. And we can do that with any group of microbes. Then we put in the antimicrobial going from higher concentration to lower concentration. So basically we dilute it out and we see where the antimicrobial inhibits the organism growth. And we call that the minimum inhibitory concentration of the antimicrobial. We use the term MIC in a lot of these other tests because we're looking at the minimum amount that it would take to inhibit that bacterium, which is very good because you want to prescribe the minimum amount of drug to the patient. Cuts down on cost, cuts down on toxicity to the patient, etc., etc. Next, disc diffusion test, the most famous of which is the Kirby-Bauer test. What we do is we put a lawn of bacteria on, we inoculate the agar with the bacteria, and then we drop discs that are soaked in the antimicrobial onto the agar. And the antimicrobial is going to diffuse into the agar. And here we've got a solid MIC, minimum inhibitory concentration around the disc. Now we call this the zone of inhibition, and we measure this taking the diameter through the center of the disc. Now you'll notice this one has a smaller zone of inhibition than this one has. These two are kind of running into each other. So you would think that this would have a higher MIC than this one. Well, you have to take into consideration the size of the antimicrobial and its charge, which determines its ability to diffuse into the agar. Now say this one, this is as far as the drug got, but even at its most dilute, it's inhibited the bacterial growth. This one, let's say it diffused clear out to here, but it only inhibited here. So maybe this one has a higher MIC. Whenever you're interpreting Kirby-Bauer results, you always want to go to a chart that shows you what that zone of inhibition means. People have gone to great effort to take out plugs of agar and figure out what the concentration of the agar is. Now, we have a variation on the Kirby-Bauer test called the E-test, where we've inoculated the plate with the bacterium we're testing, and instead of discs we have a strip that has differing concentrations of the antimicrobial, so that where the zone of inhibition intersects the strip, that is the concentration of the antimicrobial. Isn't that clever? So we get a zone of inhibition, but we can also look and see what the MIC is. Clever, huh? Now, the minimum bactericidal concentration test is an extension of the MIC and the diffusion susceptibility tests. With both the MIC and the Kirby-Bauer and the E-tests, we know that growth has been inhibited, but we don't know if the antimicrobial has inhibited the organism, shut down its metabolism, but it's not dead, or whether it's killed them, actually been bactericidal. So what we do, say we've run an MIC test, we take some of the broth that is clear, that has no visible bacterial growth, and we transfer a set amount into broth that doesn't have the antimicrobial and see if stuff grows. If it grows, the action of the antimicrobial has been bacterial static. If nothing grows, the action of the antimicrobial has been bactericidal. Now you can do the same thing with the Kirby-Bauer and the E-test. You take a plug of agar and you put it in medium that doesn't have the antimicrobial. Same thing. This is how we determine if an organism is resistant to, say, penicillin. You may have one strain that's effectively killed by penicillin and another one that you're not going to have any inhibition from it. We run these kinds of tests all the time. One, when we're testing the antimicrobial, and two, in clinical situations where we're testing what's going to be effective against the particular pathogen that's making a patient sick. Now that we know what kind of antimicrobial is going to be effective against the pathogen that's making our patient sick, now we have to consider routes of administration. We have several different ways to administer the antimicrobial, of which there are creams, oral, intramuscular, or IM, intravenously, or IV. So if you have a skin infection or an eye infection, a cream is going to be effective. We call these topical antimicrobials. If you've ever put Bactine on a cut or used an antifungal to treat athlete's foot, then you've used a cream. This is very effective when you want to have a very limited area of application and pretty much when it's on a surface that you can get to. Now, oral, I would say, is the most common route of administration. Basically, you have a pill, the patient takes it, the patient can take it on their own, you don't have to monitor what they're doing. They could take it home. Generally speaking, you don't have to use it in a hospital. This also gets from the digestive tract into the bloodstream, and you have a fairly high concentration. Well, of course, there are problems with oral administration. The first one being, can the antimicrobial survive the acid and digestive enzymes of the digestive tract? You a lot of times will enterically coat them so that they can survive passage through the stomach. Also, is the intestinal mucosa going to pull it into the bloodstream, and are you going to have a high enough concentration? That's something to consider. Also, if you get a high concentration in the blood, it's going to be quickly cleared by the kidneys. The liver kicks in. There's something wrong here. We got to take care of it. Also, the last problem with oral administration is you have to trust the patient. They can decide on their own if they're going to stop taking it. They can forget. All of these fun things. Intramuscular or hypodermic shots into the muscles is a good way to get the antimicrobial into the muscles for slow diffusion into the general area and into the bloodstream. Now, you don't get as high of concentrations of the drug in the bloodstream as you do from the one that we're going to talk about next, IV. But it has slow diffusion, and usually the antimicrobial hangs around for a long period of time. On to IV. IV, well, and intramuscular, both of these have to be administered in the hospital because we're breaking the skin. We can deliver high amounts into the bloodstream. And so higher amounts that you can deliver through oral or intramuscular means it gets into the whole system very quickly. Now, let's go back into what the kidneys are doing. If you're treating a bladder infection, having high concentrations that are quickly cleared by the kidneys is a good thing. You're taking it out of the blood, putting it into the bladder where you want it to be. But if you're treating a heart infection or something like that, you want to watch out for this effect. Also, some areas of the brain, some areas of the body are protected. We have the blood-brain barriers going on. So brain, spinal cord infections, and eye infections that are internal are very hard to treat because it's hard to get the antimicrobial into those organs. Last topic, safety and side effects. Of course, you don't want to have toxicity to your patient. We call this toxicity side effects. And there are some antimicrobials that cause some rather icky side effects. Here's two of them. There are antiprotozoal drugs that cause a condition called hairy black tongue. You would think that that was very painful. Really, it's just icky looking, and it goes away once you stop taking the antiprotozoal. But you do want to keep track of these kinds of things. Tetracycline, if you take it when you are a fetus, can deposit into the bones and the developing teeth that are inside the jaw and cause this gray discoloration that will not go away with bleaching. And in the developing bones, it can cause them to be misformed and brittle. So we don't give tetracycline to pregnant women. If you give tetracycline to young children that still have their adult teeth developing in the jaw, you can have the same effect, but it shows up in the adult teeth when they erupt. Things to keep in mind. Allergies. You've all heard of people who are allergic to different drugs. You may be allergic yourself. As I mentioned before, the two most common ones that have allergic reactions associated with them are the penicillins, and the sulfa drugs. The most serious allergic reaction is anaphylactic shock, swelling of the throat to cut off the breathing, drop in blood pressure so that you pass out. It's not good. You want to track in your patients which ones have allergies, and you want to warn patients when they're taking a new drug that allergies are a possibility. And then we've talked about the disruption of normal microbiota, especially with broad-spectrum drugs. You decrease your normal microbiota, you cause superinfections to happen with parts of your normal microbiota that survive and then can grow and cause disease, or you can leave yourself open for a secondary infection, an organism coming in from the outside and causing disease. So what do we do about the disruption of normal microbiota? Well, we try to use narrow-spectrum drugs as much as possible. Also, there's been a huge upswing in the administration of probiotics. Administer healthful, friendly bacteria. Well, that's it for this topic. Here are reminders of what you needed to get from it, and make sure you write down any questions that you may have.